Welcome everyone, and my apologies I couldn't be there in person today. I'm really excited about Dr. Scott McIntosh's talk, which is titled eHealth and AI, Ethical Issues and Considerations. So this is the second presentation that we are hosting for our CHARMS methods tech talks. And so the hope is in these tech talks is that not only are we presenting different research and aspects of methods that involve technology, but also to consider what are the ethical implications of technology, particularly when we're working with vulnerable populations. Um, so Dr. McIntosh, he will tell you a little bit more about himself during the talk and kind of the evolution of his work over the past several years. We first met about 5 or 6 years ago. I was actually doing my CTSI master's, and then I was also a KL2 awardee, and that's how we first came to know each other. And in Scott's own words, I said, "Oh, Scott, right, you're a former cane." He says, always a cane, not just a former cane." So Dr. McIntosh began with us way back and a while ago as a research assistant professor in the Department of Psychiatry and Behavioral Sciences. It was then called the Center for Family Studies at under, for example, Dr. Jose Sapoznik, who many of us know. He's currently a professor of public health sciences at the University of Rochester. He is the research director for the Division of Social and Behavioral Sciences at U of Rochester. And he also holds a role in the Rochester CTSI. So with that, I'll go ahead and let Dr. McIntosh begin with his talk, and so that we have enough time for some questions and comments at the end. So welcome, Dr. McIntosh.
Thank you. First of all, let me say I have no declarations. How do I get it to advance?
Speaking of ethical issues.
Yeah. I'll just use this arrow. And I want to acknowledge my colleagues, Dr. John Harrington, who I'll talk about later because he got a CTSI supplement that I'm on, which is about this very topic, so it fits nicely. Dr. Perez Ramos, Dr. Schultz, and Dr. Becker also are very interested in this topic and provided some great feedback. So I'm going to talk about some of my background and projects. And it's amazing I haven't used AI until now, but you'll see in each one of these projects, the next phase for all of them is going to be using AI. So it's a good transition time for me and a good learning curve for me at this time as well. I'll talk about use of AI with electronic health records, same as electronic medical records. I'll talk about the CTSI supplement, and then qualitative theme coding, which I've done a lot of over the past 15, 20 years. Okay. So actually, if I had to categorize myself, it'd be as a tobacco cessation researcher. And I've done a lot with that. My randomized controlled trial that I had as an R01 from the National Cancer Institute was about tobacco cessation. I'll talk a little bit more about that. It was the web-assisted tobacco intervention. So that's using technology to change behavior. Telephone quit lines. My colleague, who was my mentor when I first went to Rochester from here, was one of the first, Dr. Deborah Ossip. She was one of the first to create the evidence base for how telephone quit lines can help people quit smoking. So I was her right-hand person for many years with that. We had a chatting and calling center for adolescents who wanted to quit smoking, so we called it a CHAL center. I worked on something called Proyecto Doblete, which I'll mention in a minute. And a prevention research center from the CDC and, regarding global and territorial health. I'll mention something with that, including a survey we did of people in an island in the Pacific on e-health readiness. Were they ready for e-health interventions in a small little island where there's only one hospital and they serve 500 tiny islands around them? MundoCom was an online platform training. And recruiting research subjects through the electronic health record, and then looking at electronic health record data. So Proyecto Doblete, I wasn't the PI, but I was a co-investigator of it, but I get to claim I came up with the title. And so the T in the T is tecnológico and tabaquismo. The idea was these little centers in rural areas of the Dominican Republic could help people quit smoking. The original idea was like the websites, whatever. It morphed into being more of a community-centered intervention. And we showed that if we intervened in 3 communities using their local resources and all that, as a community, they would have less smoking than the 3 who were on a wait list. So it really had nothing to do with website stuff, which I'd originally envisioned. The Global Health Project, where we worked in the Pacific, as well as with the University of Puerto Rico in PR. And just to boil it down to some things relevant to this talk, is we developed and implemented a culturally tailored M-Health survey. And those of you who might know REDCap know this easily now. You know, you can create an offline mobile version of it. That was kind of new back then. And so we did publish on it, because we go into the mountains of Puerto Rico and we need to collect all the data and come back to San Juan and upload it. Okay. In MundoCom, we taught about information and community technologies, but also we did an online training for all the clinicians, for example, OBGYN docs and hospital administrators and others. We trained teams of folks from those countries and how to use information and community and technologies in the interventions they would do back in the survey back translation. And I talked to Dr. Feaster so that I point the right way. I first learned how to do that in the old Center for Family Studies, back when it was the Center for the Spanish Family Guidance Center, even. Yes. Then it turned into the Center for Family Studies. But basically, we use the Brislin back translation method. You get a bilingual team to translate an English survey into Spanish. You need a second bilingual team who've never seen the English version, take that Spanish version, translate it back to English, and then the 2 teams get together and figure out, well, why did you use that word? Oh, because of this? No, you can't assume that. Most of these people are Cuban Americans, they would use this word. Oh, you're right. So you're bringing in the cultural knowledge and sensitivity back into it, which is why a lot of folks don't like the idea of using AI for back translation. It may not know the difference between Peruvian Spanish and Colombian Spanish, and et cetera. And even then, you need to know your audience. If you're going to give it to everyone from Peru, okay, then that can be very tailored to that group. If you need a general Spanish translation, I don't know what that is, but you know, you try to find something that's going to be as palatable as possible. So you can see the ethical reasons. You'd have to train your AI very carefully how to do all that. But as I'm going to talk about, you should never just give everything over to AI. It needs to be another player in the game. And I'll tell you the punchline of my whole talk today: keep the human in the loop. So I'll return to that theme. Okay, so I was part of a study examining online health forums to help people quit smoking. And we looked at a lot of data across hundreds and hundreds of people who are on this community, talking about what to help them quit smoking and giving advice to each other. And we looked at how the super users were kind of like social influencer types. They would be there all the time saying things, kind of like the mini boss of everybody, whereas many other people were lurkers, never said a thing, never posted anything, but they were learning from the community. So that probably helped them quit smoking. So we tried to quantify that. And so the study supported the claim that network effects can play an important role in the acceleration of the online health forum, its growth and success. More and more people quitting smoking. There's a community of support for each other. And I underlined this word on purpose it opens the door to exploiting these effects in calculated ways. Now, exploit sounds dark and ominous, but we didn't mean it that way. We meant we're exploiting what we're learning to help the forums succeed and identify the users most important to its success, the thought leaders, the influencers. Well, that's not how Facebook looks at things, but they do the exact same thing. They have algorithms to exploit observed relationships between opinion leaders and others, but their primary goal is to match ads with relevant users who are more likely to engage with the content and then click things, like things, and buy things. So that's the moral difference. If we can claim moral high ground for using electronic health to help people's health versus a business model, which is its own thing. But if you compare the two, they're using similar technologies to exploit what we can learn about those online relationships. So machine learning is a system that learns as it receives new data without being explicitly programmed to carry out complex tasks quickly and efficiently. So Facebook, for example, uses that to generate the estimated action rate and the ad quality score used in the total value equation. Again, with the bottom line being profit. As part of a T course, Tobacco Centers of Regulatory Science, we got a 5-year grant from the NCI and the FDA called the Center for Research on Flavored Tobacco, is what we called it locally. And as a result of me being part of that, and I'll explain a little bit later more details of that, I was part of a committee that looked at characteristics of adolescents and young adults, AYAs, their exposure to an engagement with nicotine and tobacco product content on social media, like Facebook, like what I just talked about. And there were anti-tobacco content exposures, and they were pervasive amongst adolescents and young adults. However, the pro tobacco product marketing, including influencer marketing, taking advantage of people who are the social influencers, it persists on popular platforms, especially TikTok. So obviously we can conclude anti-tobacco product use, counter messaging, and strong enforcement of a platform's content restrictions are needed. And that's where, who decides that? Who decides the ethics of, well, we can't do this, that's harmful to health. Well, what do we care? You know, we care about profit, or we care about market exposure. So how do we get that to happen, and who decides? And those are moral dilemmas, ethical dilemmas we'll keep having to contend with. Okay, this is from a silent movie era. I thought, nice juxtaposition to, we're talking about the cutting edge of technology and human behavior. That was cutting edge in 1918. So I'm going to talk about a project that never got finished called Chatty Cathy. If any of you are old enough to know, Chatty Cathy was a doll in the early 60s. You pulled her string and she would talk. So that's artificial intelligence, kind of, right? That was the idea anyway, and I could find an acronym. I needed an acronym that I could spell something with. So to get to Chatty Cathy, which was my idea for artificial intelligence counseling on an app to help people quit smoking, I had to start with my randomized controlled trial, the web-assisted tobacco intervention. And the target audience was community college students. Here's a schematic of the whole research design of this randomized controlled trial, where they're randomized to one of two interventions. One that was static information only, and information only is effective in helping people quit smoking. Some people prefer it. Just give me a pamphlet to read, I'll know what to do, don't bother me anymore. Other people may need a lot of interactive features, including eventually artificial intelligence. But back then, the vendor that we used, who promised us originally to allow users assigned to that group to see the latest of what they came up with, they didn't stick to their word, and in fact, they created a separate little website that had interactive features as they defined them, and that didn't change over the life of the study, sadly. So we didn't get to take advantage of the more and more interactive, possibly AI stuff that was coming down the pike. And I'll show you the website in a second. But for those of you interested in online intervention research, these two strategies work the best for community college students. Facebook ads, smoked lately was what we put in the subject line, or the tagline. And I told a colleague years later, oh, we used your idea of smoked lately. We got a lot of responses. She said, Scott, I have no idea what you're talking about. So it was an offhand comment she made once, but I took it as gospel and it did work for us. And then an email blast to the whole student body at a community college. Not all community colleges were willing to do this. Of those that were willing to do it, we got our sample in a couple of days, whereas the other ones, remember the old flyers, with the tear-offs? You want a roommate to buy a car, join a research study? Didn't work at all on college campuses, not at all. So we needed to go to electronic means, and these were the two best strategies. Okay, here's what the website looked like. The static website only had information. You could click on quitting plan, have a description of what your progress might look like. And the community, I don't know what this, I can't remember what the static version of that looked like, but obviously for the interactive website, they would have a community online health forum they could go to and talk with other college students, not necessarily part of the study, but people their age from across the country. So it's a thriving online health community. So that's interactive. And they had access to videos, and they could get a text message, which is being shown amongst adolescents and young adults to be the only evidence base, for example, to help people quit vaping. So text, and it's been shown to be pretty consistently positive, to help that population quit smoking. Bottom line, cessation rates overall were low, but not unlike telephone quit line interventions. And if you know, public health impact equals effectiveness times reach. So you have something that's effective and you can reach a lot of people, that will have a bigger public health impact. So 12% doesn't sound like a lot, but with hundreds and thousands of people, that's actually a pretty good public health impact that it can have. And it's free, etc. So marketing helps. And the interactive group did have higher rates of cessation, at least in the unadjusted odds ratios. And I'll be calling Dr. Feaster for advice when we start adjusting those odds ratios. So I can get it right. So what do I do next? So we had some success with Wati. I wanted to create Chatty Cathy, which would be an app that used artificial intelligence to help you. Now, in this case, we decided relapse prevention. So I use the same subjects from my study where 90% of them, 88% of them did not quit smoking. But of the 12% that did, reach out to them first for the sample and see if Chatty Cathy could keep them from relapse. And I'll tell you why that project did not work out. But then my idea was to have Wati 2, where a cessation app would have full AI engagement for cessation as well as relapse prevention. So before I tell you about Chatty Cathy, it all started with ELIZA. Raise your hand if you know what ELIZA was and is. I saw you laugh over the end. You've heard of it, right? Yeah, I remember it from college days, but it was invented even way before my time in the 60s. And it's a Rogerian therapist that could talk to you. I remember it was on a floppy drive. You put it in your computer and take it, hey, look at this program, and it was interactive. It felt like artificial intelligence. And you'll learn why it was a Rogerian psychotherapist, because in the first parts of Rogerian therapy, not later on, a Rogerian therapist can certainly be directive. So then up front, you're establishing rapport and getting the person to talk about themselves. It's person-centered, understanding where they're coming from, getting them to have more insight. The boyfriend says, I'm depressed much of the time. I'm sorry to hear that you're depressed. So it knew to reflect back those words. It's true, I'm unhappy. So here it works. ELIZA got them to bare their soul. Can you explain what made you unhappy? So then he kind of stays in that Rogerian mode without going to anything directive. This was an early natural language processing program. Like I say, in the mid 1960s. It simulated conversation by using a pattern matching and substitution methodology that gave users an illusion of understanding, but ELIZA never really understood. The current Eliza is a chatbot version using what's called a doctor script. And it assigns value to each word a user inputs and uses the value to reorder the words in the form of a question, which is what a Rogerian therapist does. My mother never took me to the zoo. Why is it important that your mother never took you to the zoo? Well, no matter what that person said, Eliza would have said that, substituting the words that the person just said. But even the old floppy disk Eliza, out of the blue, a minute later, no matter how the conversation had been going, Eliza will say, earlier you mentioned your mother, ... to get you to go back and talk about your mother. Hey, wait a minute, that's Freudian. Why is Rogerian going Freudian? Anyway, here's where Eliza fails. I have a terrible headache. Well, maybe you should talk to a doctor. Okay, I'll do that. Can you elaborate on that? Eliza didn't know what else to say. It just tries to keep the conversation going, even when that part of the conversation ended. What are you talking about? No, I won't elaborate. I'll see you later. Why do you say that? Now you're just talking nonsense. And if you've ever used Eliza and try to mess with it at all, this happens. So it goes nowhere. So I wanted Chatty Cathy, which stands for Computer Assisted Tobacco Helper Interface. See, that's good. That's pretty grist for the mill for an acronym. To prevent relapse. And my subcontractors, we gave them $20,000 as part of the pilot study. After 2 years, they still didn't have a working prototype model. They said they would have needed another $20,000 to $40,000 to make it happen. So I was very disappointed. So that's why that never happened. But had it happened, I would have tried for an R01, because it would have been a line of progression from my first R01, the pilot study successful, just to show feasibility in any kind of a modest effect. Then I could have ideally gotten a second R01. And we were going to use, we thought of using facial recognition, and the colleagues in MD Anderson were working on that too. So yeah, I'm sad my mother never took me to the zoo. And they pout, the computer can pick up on that, or they don't pout, whatever. We program the Chatty Cathy to understand facial recognition and go with that to help further the counseling that goes back and forth. Now we know, however, that persons who are not white don't do as well with facial recognition stuff. So that's an ethical concern right there. How do you teach the AI to work with all populations? So until that happens successfully, this may not be the way to go. Okay, in a study that came out just 2 weeks ago, they compared Eastern chatbot users to Western for online therapy bots. And Western users were more likely to share vulnerable topics such as mental health and had a greater tendency to discuss sensitive topics such as swear words and death. So chatbot users acted in anticipation of conversational agents that exhibit active listening skills. Even though it's a robot, it's exhibiting active listening skills. And it fosters a safe space where they can openly share emotional states such as sadness or depression. So the idea here, I wanted to point out here, is the cultural differences. So some cultures may value certain types of language, vulnerability, et cetera, compared to another. So your chatbot better know and have been trained in the correct cultural climate. So results indicate the possibility of chatbots providing helpful information about depressive moods, especially for users who have difficulty communicating emotions to other humans. And I've always thought that, some people don't want to go on and talk to a therapist or a quit smoking counselor over Zoom or even the telephone. And remember, we've done telephone intervention research for 3 decades. But they could open up to the AI and make some progress. So you saw that first example of Eliza, well, tell me more about your depression and all that. So it can move that along. Do you need that for smoking cessation? I don't know. Some people might just want a pamphlet. I can imagine the type of gruff person that's, I don't need no fuzzy hugs. Just tell me how to quit. Okay, I'll do that. Never need the pamphlet again. If they go to a website, they'll read it once, never need to go back to the website, but it helped them quit. The website had an effect. Other people might need a lot of interaction, a lot of support, a lot of stickiness to the website. And if you know what that means, it's like one website out of California would have a random fact every day. So especially adolescents and young adults would go every day to see what the new random fact was. Like camels have 3 eyelids, you know, nothing to do with smoking cessation, but it was sticky. They kept going back to that website. I'm from Iowa, but I've never seen the movie, but you all know the phrase, if you build it, they will come, right? Believe it or not, I've never seen that movie, but I don't believe that phrase. If you build it, they won't necessarily come. How do you make it engaging? How do you reach people so that they'll go to it? And then how do you keep them engaged? If they're engaged with it, they will change their behavior. Is at least something we need to keep in mind. Okay, let me talk about electronic health records. How am I doing on time? I'm pretty good. So, I'm currently the director of the Center for Tobacco-Free Finger Lakes, which is a state-funded project where we train doctors' offices and large healthcare systems how to screen and intervene with their patients or clients who smoke or vape, and get them to refer them to the state quit line or some other intervention that's evidence-based. Well, we were interested in our own system at University of Rochester Medical Center to automatically send smokers and vapors to the quit line. If they're referred that way, the quit line will call them back. And we try to make it so that the doctor would have to actively go in and stop that. If the patient said, no, I don't want anybody calling me, the doctor would have to go do that. And if any of you know MDs, they want to do whatever's fastest sometimes. And if they don't have to do anything and this person will get referred for smoking, they'll lean on the side of, well, you can just let them call you. You know, they'll see if you want to quit, or if you don't want to quit now, ask them questions about the future. However, our institution and most that I know of did not opt for that. And it was called opt to quit. Instead, it's an opt-in program, not an opt-out. So now a doctor has to click several buttons to get someone referred to the state quit line or other evidence-based treatment. It does exist. It's hard to find. You have to train the doctors where to go and enter the information, get permission from the patient, and then send the name over the quit line. And then the quit line. So here's the doctor telling the patient to quit. This is actually a TL1 trainee, and this is a colleague who's a faculty member. You have to use pictures that you have copyright permission for. The doctor sends the name to the quit line does their thing, and they send it back to the doctor. Now, he looked like a patient here, but here he looks like the doctor. It automatically goes into the health record. That's cooking with gas. That's now electronic health things happening behind the scenes seamlessly. So the next time you go to the doctor, they'll say, how did that work to quit? Did they give you patches? Do you need another referral? Should we try Chantix now? So it keeps the conversation going. I only know of 2 healthcare systems in the 15 years I've been doing this that have closed that loop. And we can't even get that loop closed in our institution. Part of the reason is you need an outside agency to manage the transfer of structured data back and forth between a medical center, which has a lot of PHI associated with it, personal health information. And so you need it to be HIPAA compliant, get it to the state funded intervention, have their data come back in a structured manner such that a bot of some kind can stick it back in the correct electronic medical record. The technology to do this has been around for 30 years, but getting the political players in place and possibly having to pay for an outside company to manage those data, no one wants to pay for it, which is crazy because, hello, prevention, spending money now will keep people from smoking and relapsing, and their other health indicators will, of course, get better. Don't get me started. So here's what it kind of looks like at our institution. Placing the order in e-record. And every health system is different. Do you use Epic here? Yeah. Okay, so it might look something like this. Epic doesn't have a standard tobacco intervention platform in the products they sell around the country. So you have to build your own smart sets and things like that. That's the challenge. So even if 2 systems have Epic, you solve it for one system, it's not necessarily solved in the other one. So that's accessing medications and orders. Of course, we plug in there what the local evidence-based treatments are, including the state quit line and local face-to-face treatment, etc. Okay, now let me switch, still talking about electronic health records. Patient-centered outcome research. Many of you have been funded by PCORI. We had a pipeline to proposal funded by PCORI. So it wasn't a PCORI grant, it was adjacent to PCORI, building up towards a grant application, which we're in the middle of now. We had 3 tiers of funding, and my colleague is a preventive cardiologist. So he's interested in familial hypercholesterolemia. So although I sound like a professional because I pronounce that very correctly, that's about all I know about familial hypercholesterolemia. It's basically a genetic cause of high cholesterol. So it can't be treated with a simple statin. It might need to be apheresis or other more aggressive strategies to help a person's cholesterol go down. So if a physician tries a statin, after a year it doesn't work, they up the statin dose, then they switch to another statin. At that point, they should consider that the patient might have FH. Only 10% of patients worldwide and in the US are diagnosed with this. That's not the patient's fault, that's our fault. How do the physicians not know how to diagnose familial hypercholesterolemia? So we did focus groups, key informant interviews, helped build the infrastructure using EHR. We recruited patients through the patient portal. We call ours MyChart. What's your patient portal called?
My
Health chart.
Health, yeah. Same thing. So what's the ethics of that though? And we have a bioethicist on this team who says, you can't just put something in the patient portal. The doctor needs to approve that. In fact, they need to send something to the patient portal, not you. So we're struggling with when can we get the doctor to understand what FH is and then have that conversation with the patient. And so we're working with best practice alerts and in-basket features so that the physician knows, oh, they have an LDL of 190 or greater, might be FH. I can click on this yellow button here and find out more. Then it says, click here for learn a training module. And then click here for strategies on how to talk to your patient, including putting something in the patient portal. So we're struggling with this still because there's a lot of political intrigue with that. Oh, doctors don't want a new BPA. We don't want a new best practice alert. We're busy enough as it is. Well, but this one's important. Might be more important than the other 300 that you're dealing with. We shouldn't be told no because, you're burned out. This is important. Don't get me started. Okay, so lately we just had a poster. So this isn't a publication per se, but it's in the Journal of Clinical Lipidology. It's a published abstract. And the bottom line is this has to do with statin intolerance. And how do we find out if a patient is statin intolerant? Do they get pain? Like you take Lipitor, you might get pain in your arm, your shoulder, so you should switch to a different statin. Maybe you're allergic to the statin. In fact, a diagnosis is statin allergy. Well, there are quantitative numbers in electronic health records, but sometimes if those haven't been checked, what's the doctor thinking? They might type it in their notes. So if they type it in their notes, how can we pull out clues from the electronic health record? Patient reports arm pain, and maybe the doctor doesn't know they should switch to a different statin because of that alone. But that's our clue. I'll bet that patient is statin intolerant somehow. So we collected all these variables from electronic health record using manual chart review, using that famous free help labor called preventive medicine residents. And so we had a preventive medicine resident. No, it sounds exploitative, but she loved doing it. She was the main one looking through all these charts.
She said.
Yeah, she told me that. Yeah. And so we found clues. Now we need to train an AI to take it from there and look at thousands of charts. So where's the ethics? Where are the ethical concerns there? Does someone who have high cholesterol, if they learned their data were being scrubbed for whether or not they have this genetic disorder they've never heard of, they wouldn't sign a consent form for that, probably. You'd have to explain it to them and have a whole process to get them to sign it. When can you use de-identified data to scrape for data like that so we can just build a database? What if we're looking at who's transgendered or clues in the doctor's notes? It may not be a thing that the doctor can click, but there's clues in the notes. So can a researcher go through even de-identified data to build their databases on things like that? So this all hasn't been solved yet, but that's what we're about to do. In fact, all these projects I'm talking about that I've been involved with, the next phase is going to be with AI. Haven't done it yet. Johnny.
Can I ask, is the data that you're collecting here, is it rich text, or are you abstracting these into different variables that you're then running through like an ML algorithm?
I'm about to get to that, and
sorry.
That's okay, with the caveat that I barely understand it myself, because to get a straight answer from someone who's done this in the past is really hard. But as I understand it, instead of relying on medical residents to help us out, there are AI programs that, like, I think Dragon, is it? Maybe, your pen, something. It's a platform for that. So you take all these data, stick it in there in the platform, with the quantitative data and the qualitative data as rich text, I believe.
Wow.
And then it knows to look for themes. Oh, here's a word that means something like statin intolerance. Here's statinology, here's statin, here's whatever. And then you'll know how many women said that, how many men, in which age groups and all that. I mean, it sounds like magic to me because we're not there yet.
It's incredibly powerful. Wow. To digest all that information.
Right. And that's the hope of this. So we have to make sure we're ahead of the game ethically before we get too far down this path. So we use an EHR-based algorithm to identify, well, we want to do this. Maybe the AI could already be in Epic. Maybe just ask Epic to go do this, rather than extracting all the data and having a resident or another AI program do it for research purposes. The AI should live in Epic and do this for any condition or whatnot. But the good news is that could help identify gaps in care, such as familial hypercholesterolemia, statin intolerance, smoking cessation, and identify where we can improve our treatment. Okay, natural language processing, and this is where I'll try to address it as best I understand it. So I already talked about some of these ethical considerations, and here's what Epic looks like. So these would be the doctor notes here. It looks like just a couple of lines of data, but sometimes they write a paragraph, or using a dictaphone, which my resident assures me everybody wants to do that because it's much faster. Right. Then that copies over into the electronic health record. But identifying people with specific concerns, is that ethical? Trans people, other persons with divergency, they wouldn't want anybody else to know, and maybe the doctor was just guessing and put it in the notes. How do we solve those ethical issues?
Can I interrupt and ask a question from online?
Yeah.
In your studies and the work that you're doing, where is the consumer voice? So how are you guys adequately evaluating some of the ethics that specifically have to do with the clients?
We keep that in mind, certainly in the familial hypercholesterolemia world. And in fact, one of our first publications was on patient-determined themes, on what to look for in the patient portal and in the electronic health records. So we're trying to build that strategy, patient up. And in fact, I don't know if I have it listed, but I'm first author of one of our papers on patient voice. I'll find it before the end of the talk. We always do key informant interviews and focus groups with patients as well, so that they do have a voice in what we're doing. And that's kind of just true in our department and our university. We're always very mindful of that. Is that answering your question?
It is. And I guess I'm also wondering when the concerns are going to be different, sometimes similar across client population, depending on what the researcher may want to see or the institution may want to see. Are those key informant interviews then targeted to ensure those nuances are there? To
the right patient or consumer group, absolutely. Right. And we've started something in our cancer institute called the Community Cancer Action Council. And I've recently been made a liaison for that between our cancer institute and the CCAC, which is made up of a lot of people I know and people from the community, people from industry. And it's kind of like a super community advisory board. And in fact, we go to them like, hey, so-and-so wants to do this new research study looking at this particular population. Any of you interested in being on our community advisory board? So if it's African-American women with breast cancer, we'll find some people from that community Cancer Action Council to be on that board. And as they join all these different boards, they're becoming more knowledgeable as a community-based group. So we're really trying to tap into that as well. All right. So what if you have an adolescent and you want to ask them if they smoke? You're a pediatrician, you know not to ask that in front of the parent. Of course the kid's going to say no, you know, and so and often pediatricians want to speak to the adolescent alone, and they get to, so they'll ask a question like that. But then, well, you need to go to this treatment. You need to do this. We'll send you to the quit line. They'll be calling you back. Well, not at home. They better not call me back at home. I don't want my parents to know. So these ethical considerations on what we can scrape out of electronic health record, how do we act on that? You know, if we're just looking at prevalence or where referral sites go to, things like that, that's fine. But how do we actually intervene when it might be needed? Okay. Here, I'll let you read this. Ethical considerations, privacy and security, informed consent, data bias, AI models being trained on biased data can perpetuate or exacerbate existing biases, leading to inequalities in healthcare. Even the facial recognition thing I talked about earlier, it might assume a non-white person is sad about something, when in fact, in that culture, it might be something that's not sadness. So it would make the wrong assumptions. Clinical autonomy, it's like, oh, I don't have time to do all this with my patients. I'll just turn it over to AI. That takes away the physician's accountability for the intervention that the patient might get. Dual use dilemma, electronic health records and AI systems can have a dual use, including potential applications in surveillance and data mining and creating databases. Well, can you use healthcare data for these purposes that's beyond patient care? Obviously, we do for research, but where do we draw the lines and when? And I would say it would be project specific. But somebody needs to be in charge of looking at that. Okay. So we got a CTSI supplement, and Dr. Harrington was the PI of that. And I was brought on because of my skills with focus groups and surveys. And also I've done online training. So we're going to be training KL2 scholars and TL1 trainees. And I understand you now have a K-12, whatever, you know, they'd be the type of target audience as well. And by the way, I should have said this at the beginning. If any of you think of collaboration ideas between our institutions, speak to me afterwards. But anyway, this CTSI supplement, which I'll show you the research design for it in a minute. But let me back up a second. Have any of you heard of CLICK? Have any of you been KL2 scholars or TL1 trainees or program directors for either of those? If you had, you would have gotten me. Yeah, Lindita has. And I'll show some data points I told her earlier. Some of your data might be on my screen here. So we were the survey team for the coordinating center for all CTSIs. So we weren't employed by our CTSI, but we were rather separately funded. But CLICK is over, and there's a new coordinating center. My research team actually stayed intact, and we got a subcontract to do that for the new coordinating center. So people cannot escape my surveys if you're in the CTSA consortium. Another idea I want to put forth at this moment has to do with translational AI research. And consider that there's specific learning model, machine learning models for sepsis predictors, diagnostic decisions. I talked about FH, for example. There are foundation models, which I know nothing about, large language models and other generative TI, AI, but I'll be learning those things. So one umbrella term could be translational AI research. As we've already talked about, we need to make sure that community values and ethical norms are increased and implicit bias, because these AIs might be trained on data that have implicit bias in them, because the goal is a trustworthy AI. And I'll show you a good example of, do we trust this or not? Okay, so the supplement is to create a new course to train translational scientists in ethical awareness and competency. So it's called Capacity Building in Bioethics for Scientists Across the Translational Spectrum. The ethical challenges we'll be looking at is repurposing anonymized data that were collected in clinical contexts without the patient's explicit consent, developing machine learning algorithms that may draw from sources that have biased, inaccurate, or confidential data. This is saying it more eloquently what I was saying earlier. Changes in hospital policy around prescriptions that may affect treatment choices for patients. So you develop algorithms, you develop an AI, then something changes institutionally. You have to stay on top of that. Determining when we should report individual level results back to patients. When they were, for example, were or were not formal participants in a study. And I was actually on another CTSI supplement that looked exactly at that, and I'll show you the punchline of that in a minute. But this course will help emerging researchers develop the awareness of and tools necessary to engage with these ethical tensions. When we're done with the project at the end, we might be able to partner with other institutions. So you guys get first dibs because I'm a cane forever. We anticipate offering it to the U of R community in the spring of 2024. Mainly our K awardees and trainees working on clinical trials that involve research volunteers. All right, so here's some diagrams with our training we're calling team, translational ethics in action modules. And we want to find out from our key informed interviews and focus groups, what are these ethical challenges? So you've heard a lot of me opining on some of those. What are our clinical researchers telling us they believe these ethical challenges are? Then we'll develop, pilot, and evaluate an 8-session course, each session being 2 hours, and pre and post surveys, and that's why I was brought on board, because I speak REDCap. And then afterwards, and I think I contributed this to the grant application, let's make sure we look afterwards. Did we get it right? Go back to some of those same people and said, you took our course, you were part of an interview done before, did we miss anything? Here's some results here. So doing qualitative interviews at the end is always a good idea. So we will do the interviews, a scoping review, a philosophical analysis. No, I don't know what that means, except sitting around with a cup of coffee and your colleagues and coming up with ideas. But we develop and implement the course and evaluate its impact at the end. And I'll let you read some of these while I get a sip of coffee. Five minutes left. Oh my goodness. Let me skip to the one of the punchlines is doing qualitative theme coding and using something like Atlas TI to scrape your data from key informed interviews and focus groups. And I've not done that yet. What I've done is by hand with my residents and even my undergrad students. We're a machine. We know how to take a bunch of data and put them in categories and then come up with themes. So in this study, we found 163 themes. Well, that's too many. So we collapsed them to mega themes and ended up with a list of 10. So of those 10 themes, each theme might have anywhere from 5 to 20 sub themes under it, but it makes perfect sense. And but we did that all by hand. And I felt guilty, like, aren't there machines that can do this? Well, there are. And oh, by the way, Loon Theta, this is the survey you might have gotten as a KL2 scholar. We actually did hand coding for one of the open-ended questions in our survey that went to all trainees and scholars. What strategies are you implementing to maintain your productivity? And K's were different than T's in the strategies they used to maintain their productivity. Long story short, it mainly could be because more Ks were married compared to the Ts. So family issues, working from home, being able to be productive, not having to be in a laboratory, things like that might explain most of the differences. We're doing a follow-up now to see the long-term impact. And we're just now hand theme coding those data. But one of my undergrads has learned Atlas TI. Oh, great, let's give it to Atlas TI. No, Dr. Harrington taught me, keep the human in the loop. Remember when I said that earlier? So we're gonna have Atlas TI be one of our coders. We'll train it as best we can, look for false positives, false negatives that it comes up with against my staff who are gold standard. The ground truth, I think, is the term used in machine language training. So that's one takeaway from my talk is, and this is what an Atlas screen looks like, not that different than the screens we used using Excel. Here's all the quotes, here's the themes we have in the next category. So we'll teach Atlas to do that, correct its behavior, and say, no, this was a wrong theme, or you missed this really important theme, and then putatively, it will now do better the next set of data we give to it. So if so, that's how we would use AI, not just give all our data to that and not be in the loop. Okay, here's the punchline, or the fun part of my talk. What are the salient ethical issues in the use of AI in e-health? Let's ask AI what it thinks. So a colleague of mine said, well, let's feed this information into ChatGPT. So I used his exact way he phrased it. And in hindsight, we both wish we would have used the word e-health rather than health, but it doesn't matter. We still can. And so he did it, but then I had a colleague of mine do it, and at the same time enter it into another chat program called Bard. If any of you are familiar with it, so it's this competing thing. And Elon Musk invented one last week called Grok. So all these AIs are out there. Well, what do these two even agree with each other? And so we need to confirm the validity of their results with a ground truth source, like I talked about earlier. In my case, Dr. Harrington's a bioethicist. What does he think the major issues are? Well, ChatGPT came up with these 10 or 11 categories. I won't go over them at the moment. But Bard only came up with 5. But I looked at both of these side by side. Here's the 10 that ChatGPT came up with. I liked them. Good variance here and a good variety of ethical concerns. Bard only came up with 5 of these, and they don't all overlap with what ChatGPT came up with. But if you look at what ChatGPT said, it said the very innocuous phrase of, oh, these are important. Yep, we should study it. Whereas Bard gave examples and advice on what to do next. So I'll take what these two things said and present it to my bioethicist colleague. Then we'll determine perhaps what a better list of categories can be. So we're always keeping the human in the loop. Okay, thank you very much. Dr. Feaster.
So, very interesting. While I was listening, one of the things you're talking about, sort of the beginning of using AI.
For me, yeah.
And I've been doing my PCORI grant was to actually look at methods of trying to say who's going to do best under different treatment scenarios using machine learning. And we now currently have a grant where we've gotten a large trial on substance use treatment and looking at who does best under different medications for opioid use disorder. And I am very concerned. The next step from what you're doing is not just having a chatty Cathy that does a specific intervention, but a chatty Cathy that knows your history, knows your social media presence, and decides how they're going to approach you.
And remember each conversation as time goes on.
Based on how they've seen other people that look like you respond. And that's where I think we have the real ethical issue, in that there are certain people that are less willing to interact, that have fear of the medical system, have medical mistrust for very good historical reasons, that we will perpetuate the existing system rather than trying to change the system to address those problems.
Yeah. And so are you training your AI as you go along?
We are not using AI. We are trying to see whether we can get predictions that give us valid and precise estimates of how much better someone will do with one treatment versus another. And I'm not sure that we can yet, but eventually that's going to happen. I mean, one of the ethicists one of the people I've talked with about this gave an example of a group that was using AI to try to predict adolescents that might end up having problems. Well, they're using data that was gleaned from a system that systematically targets Black and brown people for more surveillance, so that we could then be perpetuating the unequal system we have by building that into that type of system.
Absolutely.
So I mean, I think while you've touched on all those, they were at a higher level, and I don't think they really got to what we could be doing to ourselves and to our systems if we're not very, very careful.
Right.
So,
And that's the whole implicit bias part of it too. It's baked into the system right now. How do we unbake it?
yeah, all our data is a result of the system in which we live in.
Just to comment on what he just mentioned, I'm a programmer type data. I'm not medical at all. The historical side does get into the fact that Mary or John Doe might have started with problem A, which progressed, got cured, whatever you want to use, so that a year later, looking back on that old data, we need to make sure we keep everything in proper perspective, so that 6 months from that, looking back, they don't go all the way back and say, no, he's got tobacco problems. No, 6 months later, those tobacco problems were taken care of.
The data persisting.
So it's just
Yeah, it's hard enough for a therapist to keep those things in mind. So we need to train systems to be able to do that. A colleague told me that ChatGPT-4 is 100 times smarter than GPT-3 was. And that GPT-5 will be something like 100,000 times smarter than that. That kind of a system could keep in mind all those things you're talking about. So if we can convince it not to take over the world, but to rather help people get off of opioids, I see success in our future.
ought to be back.
I've got extra slides, by the way.
Question,
Yeah.
as someone who just got her master's in mental health counseling, I look at Chatty Cathy and I'm like, oh, that's really cool, but are the robots gonna come and take my job? It's sort of thing, you know what I mean? But you say keep the human involved.
Yes,
How would the human be involved in something like Chatty Cathy?
double checking the work for one thing, because Chatty Cathy could take a client down the wrong path for months.
Uh-huh.
If there's not a human overseeing that, that's gonna do damage, and we wanna have do no harm as our motto. So it always has to be double checked and calibrated, if you will. So are you in the Department of Education?
Yeah, that's where I got my.
That's where I got my PhD, actually. So I think that's an arena where Chatty Cathy, like we talked about earlier, could be for people who don't want to come, even on a sliding scale fee. They don't want to go to your Institute of Family Living. It's still called that.
They closed it.
Ah,
Yeah.
I think to the point Rosanna's asking, but also what Dan was saying, I think one of the sad realities is that there are terrible therapists as well and mental health providers. And a lot of our theory and methods that were developed weren't developed with certain groups in mind. And so some people aren't good therapists for certain minoritized groups in terms of actually helping people. And some people may walk away from those therapists. So how do you build AI systems that actually can also say, yeah, that's widely accepted, but it's not evidence-based within these minoritized communities? Or, I think that's one of the issues, that so much of what AI has to pull on, again, is steeped in a lot of systemic issues. So unless AI is confronted with another algorithm or enculturation process that's actually critically conscious in many regards and can say, oh, boom, I see it's pinting that, if I go down to Overtown, it's going to be X, Y, and Z, but I need to come back at it and say, you need to filter in what has been kind of displaced on the Overtown community so that you are not using that algorithm to think negatively of those residents. So I think that's the thing, like AI can learn from so much that's out there, but so much that's out there is steeped in who has power and what oppression looks like. So I think it's a beautiful tool and it's a scary tool as well.
Yeah, actually related to that, Sanisha, I think, and that fits with what Scott was saying, keeping the human involved, is as these things are developed, there needs to be a lot of surveillance of what they're doing and how they're affecting our systems. And perhaps some interventions with the AI to change things when we see them going in the wrong direction.
Right.
And that I'm not sure how to do that, because
and I think also the important thing is changing the narrative or the messaging around AI, because Scott, you talked about the tension, and there is this tension because the AI is learning, and we're entrusting it to give us responses and to give us results when it's still in kindergarten and in elementary school, and we're just thinking because it speaks eloquently that it's actually giving us the responses, the correct
it's no
responses.
frontal lobe.
Sorry, what did you say, Dan? I missed it.
There's no frontal lobe.
No frontal lobe, right?
It's also, if it runs into a question that it is not programmed for, it's just gonna go to the default. Well, would you repeat that, please?
Yeah. Which a Rosarian therapist might do. But Dan, do you remember the Angel effect?
Oh yes, the famous Angel
So the
effect.
Angel effect. He was a very abuelo looking guy, very avuncular. He was the best therapist, not just because of that reason, but he was a really good family systems therapist. All his patients, all his families did really, really, really well versus anybody else. We called it the Angel effect. Why? So he should change. He should train an AI to do therapy. If the flavor of the therapy is family systems therapy, to just plug in the textbook.
Adolescent families.
Well, especially for a tailored audience, for the right cultural input. So we're increasing that cultural input, decreasing the implicit bias against that same thing. And remember that chart earlier, that increases the trust in AI. Because that's what we want to do, is have trust in the AI. I don't trust Facebook's AI, but I want to trust AIs that were built for good.
True.
Do I have another minute?
I mean, we're 6 minutes over time, but I feel like if everybody's still here, then we can.
Then let me ask the question, good or evil? Anybody know this quote? Johnny, what is it?
That's from Dune, isn't
From
it?
Dune.
Yeah.
Thou shalt not make a machine. That's why there's no computers in Dune. Thousands of years ago, they got rid of them because the machines rose up and tried to kill all of humanity. Do you remember this one from Star Trek? Anna, what's the name of the episode?
But I remember.
So they created an android artificial intelligence, Kirk, who was exactly like the real captain, except he wanted to take over the galaxy. Who knows what this is from?
2001. Space Odyssey.
Oh,
Yeah.
yes.
Here's Hal, right? He's reading their lips. They thought they were outside what Hal could listen to. It was definitely insane, I think, was the premise of the story. Not evil, but just crazy. But I tried to get rid of them. This one's for good.
Knight Rider.
I think his name is Kit.
Yes.
It was good.
And of course, Mark Hamill recently said, we had this important space opera going on, but what drew people to the movie was two robots arguing over whose fault it was. And that was one of the charms. And then, of course, here's what we all fear could become a reality: Skynet killing us all. So you talked about I'll be back. That's
Yeah, no.
And then here's a point I wanted to make. This is the same matrix. The same data has the same matrix as his evil brother Lore. But Lore wants to take over the galaxy. What's the difference between these two otherwise? Where does that moral, who trained this one and why did that one turn out so badly? I don't know. But
They left out a comma in the program.
they did, yeah. And of course, the replicants who went rogue and tried to kill humans. Ultron from the Marvel universe, but didn't Vision have the same matrix? So the same matrix can be good or evil. Same thing with a counselor AI. Could be either horrible at their job, or it could be trained by Angel Perez Vidal and become the best therapist in the world. Of course, the evil Borg, and I'll leave you with this one. She was overtaken by the artificial intelligence called from the Borg, but she